Okay, I think that we are all now just another two colleagues that join us. Enrique, Dr. Garcia Prince is the chief of the department here in Santiago de Compostela.
Hi, nice to meet you.
Great to meet you.
And Dr. Álvaro Sánchez is another colleague, thoracic surgeon here also in Santiago de Compostela.
Great to meet you.
Another one, he's still is at home today. He's on some leave, but we are the team, and there are also two residents that currently they are in another department right now.
Yeah.
So let's start. So today let's start this new session of Compostela Thorax Life Connections. So today we are honored to have here Dr. Henrik Hansen. Dr. Hansen is a thoracic surgeon in Rig Hospitalet in Copenhagen, in Denmark. He's, one of the giants in thoracic surgery with huge experience in minimal invasive procedures. In fact, he's the chair of the minimal invasive program in his hospital. And today he's going to talk about very, very interesting topic, the lung volume reduction surgery. So as usually we do, we are going to start with a 20 minutes lecture, and after that we are going to move to another 15-20 minutes discussion. So Henrik, thank you so much for accepting to collaborate with us in this educational sessions that we do here in Santiago de Compostela. So whenever you want, just please, you can start. Thank you so much.
Well, thank you for the invitation, and now we should see if we can share the screen so we can have my lecture.
Okay. Just 1 second, please.
Yeah.
Okay, I think that now you can try to share the screen.
So, well, I've chosen to call my lecture Lung Volume Reduction Surgery from the NET trial until today. Actually, lung volume reduction surgery started in the 50s, but it was a forgotten procedure. So, what we're dealing with is emphysema in large lung. It's an end-stage condition of COPD, and it is heavily smoking related. There's a few other patients with the severe emphysema that's not smoking related, mainly alpha-1 antitrypsin deficiency. Denmark is a population of 6 million people, and we have estimated throughout Denmark that there are around 400,000 patients with COPD. Of course, not everybody gets emphysema, but from calculations from other European countries, the end-stage emphysema that might be suitable for surgery is around 2,000 annually. So that's quite big numbers if we get to do surgery on those patients. We should also bear in mind that end-stage COPD has an expected remaining life expectancy of 5 to 10 years, so it's almost as bad as our cancer patients. Well, as I said, lung volume reduction surgery has been in the area for many years, but it was really this paper that when it hit the news, the thoracic societies in the mid-90s, it created a huge interest. So it was Joel Cooper from St. Louis who published a paper on bilateral lung volume reduction surgery for COPD with some dramatic results. At that time, it was mainly done by open surgery, bilateral, often by sternotomy, and using a traditional stapling device where you more or less cut 1/3 of the lung away during the procedure. Nevertheless, they a year later published their results of the first 150 consecutive bilateral lung volume reduction surgeries, and the result is really dramatic. Looking at the patients, an FEV1 of expected 25% in large lung with TLC and residual volume well over the normal, and the majority requiring supplemental oxygen. Their 3 months mortality was 4%, and 6 months follow-up showed a dramatic increase in FEV1 of 50%, a reduction in residual volume, and that the majority of the patients no longer needed home oxygen. These papers and the huge interest in the 90s led to one of the few big randomized trials we do have in thoracic surgery, the National Emphysema Test Trial in the US. It was designed as a prospective randomized multicenter study, long volume reduction surgery versus optimal medical treatment. Primary outcome after 2 years were survival and maximal exercise capacity, because that means a lot for the patient. So including patients in a 4-year period, 17 centers in North America, 1,200 patients randomized for surgery or medical treatment. The very first paper that came out, and in a paper like journal like the New England Journal of Medicine, was this one: patient at high risk of death after long volume reduction surgery. This title alone killed the procedure more or less. People didn't read the paper. They didn't even read the abstract. They just saw this title, New England Journal of Medicine says patients die of long volume reduction surgery. Well, if we look a bit into the details, at the point of the publication of these papers, 1,000 patients had surgery. In a subgroup of 69 patients, the 30-day mortality was 16% compared to nobody in the medical treatment patient. So it is 7% of the patients where there are higher risk. And if you analyze proper, it is a patient with really poor lung function, FEV1 below 20%, homogeneous emphysema, and a diffusion capacity less than 20%. 2 years later, the result of the NET trial was published again in New England Journal. And they divided the patients into 4 groups. Group 1, upper lobe emphysema and low exercise capacity. This group lived longer and had a better lung function. Second group, upper lobe emphysema but high exercise capacity. They did get better function, no survival benefit. Then the diffuse emphysema and low exercise capacity, it doesn't matter, to be short. And finally, the diffuse emphysema and high exercise capacity, they had worse survival, the group that we discussed former on. So overall, the mortality was 0.11 deaths per year in the treatment group. And with the patients with predominant upper lobe emphysema, there was a highly significant benefit also on survival. Looking at some of the numbers, here the survival numbers in the different groups, and have to mark this, the group D. If you see that the dark line is medical treatment and the gray line is surgery, and this probability of death, there's a huge difference, saying that the surgical group has less risk of dying from surgery. And in the majority of the other groups, it's pretty similar. The high risk group, it is B. You see that there are higher risk of surgery in the beginning, but it's few patients. Looking at improvement of exercise capacity, actually there was an improvement for all patients, also a significant improvement, and especially in the upper lobe group with low capacity, there's a marked improvement of 42%. And we see that within 1, 2, 3 years, there's still a benefit. It is less, but there continues to be a benefit. And actually, when I talk to my patients, I tell them that you can expect a benefit from 2 to 5 years, but at some point, you will probably be back to the same level as before. Well, quality of life gain the same benefits, so it is likely to be superior for the patients. So a long-term follow-up published in 2011, we see that it gives clinically meaningful improvements, and there have been several studies who have published long-term data and reanalyzed the data. And I like the conclusion here that actually long volume reduction surgery is an underused therapy. But really, the first paper from New England Journal more or less killed the procedure. One of those few departments that continued to do it in pretty high numbers was the Zurich thoracic unit by Walter Weder and I visited him and I got a few slides from him, and I really like the next slide. It's a slide from Valderveda. You all know the old spaghetti western, the good, the bad, and the ugly. So for Valderveda, a good patient is those with symptoms, hyperinflation, heterogeneity, and a proper diffusion capacity. The bad is the one with low DLCO, low FEV1, and homogeneous emphysema. And then the uncertain is those with alpha-8 antitrypsin, small airway disease, and neither heterogeneous or homogeneous emphysema. What do we mean by this? Actually, you see it here by morphology. A marked heterogeneity is like upper lobe emphysema or lower lobe emphysema, and the homogeneous is a bit of everything all around, but no really marked area. And then you have the intermediate heterogeneity that we actually address nowadays in surgery also, where you have areas like, for instance, the segment 6 or part of the lobes that actually has poor function from diffusion and ventilation. And from the Zurich Clinic, they published a paper on lung volume reduction surgery in non-heterogeneous emphysema, showing that the feature that it is not as good as the heterogeneous, but still you do have a benefit there for a period. So in selected patients, the diffusion capacity of 20% or more, you actually might benefit from having just a part of the lung cut off. So in Valderveda's experience now, the very good is those evidence-based heterogeneous with symptoms, and the maybe not so bad, I'll not agree with him, is those with, or maybe not so bad, and we do actually surgery those is sort of non-heterogeneous and proper diffusion capacity. Still uncertain is low diffusion capacity and heterogeneity. I would say diffusion capacity less than 20% is one of the clear-cut exclusion criteria by us. Well, as I said, form on, you have a benefit for a period, and then you will decline to the pre-surgical level. It's then a benefit of redo lung volume reduction. Again, the Zurich group have showed that, and we have also in our experience done redos, so it can be done. Of course, they will probably have a longer postoperative stay because adhesions, losses of adhesions, and it was shown here in the Zurich paper that they stayed median 2 weeks versus 9 days for the first time surgery. And quite a few had reoperations due to air leaks. In our experience now, we have done well over 170 cases. The redo for air leaks is around 10%. But still, from this paper, you can redo, but you should be willing to take the enlarged risk. Another interesting aspect is actually lung volume reduction and lung cancer. It's quite common actually, and there are several papers showing that you might actually combine the two procedures. So nowadays, if we have an emphysema patient with a lung cancer, and we suspect that the lung cancer is in the potentially target area for lung volume reduction, we work the patient up as a lung volume reduction patient and do a combined big wedge resection of the cancer and the devastated lung tissue. So we have a few patients also where we have done this combination. So that was the scientific background, and now I will run through our experience in Copenhagen. This slide I choose is in Danish, but it's quite clear. So we are doing all lung reduction for all Denmark because we are having the lung transplant program here. So that allows us to do it. So the patients have to be seen by a pulmonologist locally, and there's some strict inclusion criteria if they want to transfer the patient for us for potentially lung volume reduction surgery and or valve lung volume reduction surgery. So the age between 40 and 75, too old, too many complications. Marked hyperinflation and emphysema, and you see the parameters of lung function there, and FEV1 20 to 45%, at least a TLC of 120%, at least a residual volume of 200%, and that percentage should be higher than 58. That's international criteria. Often we say it's in the 60s. and a minimum diffusion capacity of 20%, certain extent of dyspnea, and they should have a new CT scan showing that they have no infiltrations, no suspicion of a lung cancer. And before they refer to us, they should have optimal medical treatment, including a COPD rehabilitation and maybe have home oxygen. Exclusion criteria: tobacco smoking within 6 months, chronic bronchitis, bronchiectasis, more than 2 to 3 exacerbations or pneumonias demanding antibiotics annually. If the lung function can be treated well with drugs, if they get too much steroids, it should be less than 10 milligrams daily for the last 3 months, or if there are other major disease, typically cardiac conditions. Then the patient comes to a hospital, and every referral we discuss in an MDT conference. Every second Friday, we have an MDT conference on emphysema, where the pulmonologist, the thoracic surgeon, the radiologist, and the nuclear medicine people participate. If the patient is found suited, then they will have a workup in the transplant unit of pulmonary medicine with extended lung function test, cardiological examination, and minimum an echocardiogram, a 6-minute walking distance test, arterial puncture. Then we do a SPECT scan and a clinical visit. The SPECT scan is a perfusion diffusion CT scan, and that's really important. That's some new things we do here in Copenhagen. After this workup, we'll see them again on the emphysema conference. If they have one lobe that's really hyperinflated, really with poor function, and the fissures is intact, so there are no backdoor open, no connection to the other lobe through the fissures, then we will go for the valve treatment, and it's by the pulmonologist. There are other candidates that found suitable going to the surgical team, and it's me and one other surgeon doing it, and we see all the patients in our outpatient clinic, inform them about the success rate, risk, and if there are any contraindications. And now and then, even though the workup shows they're a perfect candidate, I turn them down. So what I do tell the patient is that there's a 50 to 60% chance of having an improved outcome. There's maybe 25% chance of minor improvement that really means not that big, means anything that big, and then maybe 20% risk of no improvement at all. Inform them about the mortality rate. It is 3%, 30 days mortality. Inform them about that 1/3 to 1/4 have a prolonged hospital stay, meaning more than 1 week, and even a few ones more than 1 month. So the patient should know that this is not a super treatment, and they should know what they're dealing with, what are the risks, and are they willing to take that risk for aiming for a 50-60% success rate. In the surgical arm, then they do have surgery and see them 4 weeks after, and also all the specimens sent to pathologist. And then they are followed up by the transplant pulmonologist with the same program as the workup, 3 months, 1 year, and 2 years. So we have loads of data now. And during those visits, we discuss maybe a new operation, or maybe they are transferred to the lung transplant program. The VATS is done by our standardized Copenhagen approach 3-port anterior approach. And the technique for the lung volume reduction is, first of all, do as little harm as possible. So it's always VATS. We just do one side at a time. We might do it staged, so we do the other side 3 to 6 months afterwards. We do never grab the lung. We just push it into the tissue. If you put graspers on the lung, you would make scars in the pleural. You made a possible port for air leaks. There's a specialized anesthesia, especially focused on recovery period. That's one of the things I learned from Wisting Zurich, is that the patient after surgery turned to the back, extubated while they're sedated, then they have a laryngeal mask, and they have like half an hour to recover slowly on the laryngeal mask instead of the classical extubation where you just pull out the tube and they cough heavily, making a major pressure in the chest, and you might rupture the lung again. No epidurals, as little morphine as possible, because they'll give nausea, vomiting, and again create problems. So this is a SPECT scan. So the red areas shows this is for a ventilation So that's where this poor showing that is right upper lobe that had the worst ventilation in this patient. So this is one of the things that we use for planning the surgery. So right upper lobe, and you can actually see that the segment 6 of the left lower lobe is also quite poor. So this means this is a guidance of how our technique will be. So instead of the old cutting 1/3 off of each lung, now we go into remodulation. So find the specific areas by this different modern scans, the SPECT scans, and remodulate the lung by typically doing 3 to 4 minor peripheral resections of the tissue. And I like it to be minor resections because if you make a major resection on a collapsed lung, then when it really expands, there'll be a huge stress on the stable lines and you will rupture it or rupture the tissue next to the stable lines. So instead of one big incision, several minor incisions, several minor resections to avoid those forces on the re-expanding lung tissue. So by surgery, we use the Signa, we use electrical devices, really gentle, not compressing hard by surgeon. And we do not touch the lung, we do not touch the pleura, do any dissection in the pleura, keep it as a film over it. Actually, we do not do reinforced staplers because what our experience tells us that when we do have to redo, it's seldom the stable line, it's next to the stable line, and anyway, it will not be covered by the reinforcement of the stapler. We don't dress it with anything else, and normally we don't glue it. We glue the lung in like 25% because of some air leaks next to the stapler line, and it's Pro-Gel we use when we need to glue. So in summary for the technique, no touch technique, only touch the lung with peanuts, peripheral staplings, vascular magazines, so it's a tan magazine, so it's really tight to close it, typical 3 to 4 sections, 15% of the lung, water sealing test, 2 tiny chest tubes, and really tight around those. Many of those patients are quite slim, and we don't want false air to go in. So pass suction only -2 we have published on lobectomies, that's beneficial, and we want to avoid major suction on the TOPAZ system because that can also create air leaks, and then this procedure of recovery on the laryngeal mask. So just a few seconds of a movie showing the resection. You have this emphysema lung here, quite diffuse and some marked areas, and then the grass plates on the tissue to be removed, remaining is left there using the vascular magazine, and then slowly do the resection with that. So status by us, for the first 3 years we did this revitalized program, and this has been published at the ESTS Congress. So our results for the first 92 patients, now we have done more than 170 patients. Our 30-day mortality is 3%. Our redo procedure percentage now is 9.5%. And the median hospital stay is 5 days. The mean is longer because we have quite a few patients with prolonged air leaks. But you do see that on almost every of the numbers there, we have an improvement. There's no difference in the diffusion capacity and the 6-minute walking text. It's 100 meters more, but it is not significant. It's nearly significant. So probably when we redo the numbers, it will be significant. And finally, slide to show the difference. So this is a patient had a right-sided lung volume reduction surgery. And look at the diaphragm. Now the cupola of the diaphragm will be reestablished, where on the left side you still have major emphysema and you see the flattened diaphragmatic cupola. Well, that was all for the slides. So I'm happy to answer any questions. This was a short overview of lung volume reduction and a short overview of our own experience. And I think it's really important to have the close cooperation with other specialties, nuclear medicine, radiology, pulmonology, and surgeons, so we discuss it.
Okay, thank you so much, Dr. Hansen, for this outstanding lecture. So let's start this discussions. I don't know if you have any questions in the room, or we can.
Dr. Hansen, thank you very much for your presentation. We appreciate that you share with us your huge knowledge of this theme. I'm surprised that you perform only one procedure of one side, and then you wait 3 or 6 months, or maybe you don't perform the other procedure on the other side. Why, and have you noticed that maybe you can have as a result an herniation of the lung to the operated side?
Well, we don't see any side effects by doing one side at a time. We don't see a shift of mediastinum or any problems. We have chosen this for safety. As I said at one slide, do as little harm as possible. So we were afraid of having people really with prolonged air leaks and tubes in both sides. So we have made a literature research showing there's no really good papers. There are some papers from the 90s with open surgery showing that maybe the bilateral gives more benefit for lung function, but also have higher risks. Actually, now we are preparing one of our younger colleagues to do a PhD study, and one of the studies there will be a randomized study, unilateral versus bilateral. Looking at our conference, well over half of the patients might be suited for bilateral, but still 40–45% only have changes in one side. And in our experience, half of our patients at some point, if they had lesions on both sides, will come back and have the other side done. So quite a few patients 3 to 6 months after have the other side, but also some patients, then they actually perform quite well 1, 2, 3 years, and then we do the other side, and then we expand the benefit of the surgery for a while, and we don't have to do a redo on a side where we have had the stapler, had adhesions and so on. So we should think that the majority of those patients here, they're quite elderly, and they just want some quality of life for a certain period, and we might actually not prolong their total life expectancy. So that is the reason for doing as little harm as possible. But still, if you look at the literature, it is an unanswered question. So actually, we are planning to do a randomized study at some point.
Okay. No, just in this way about this question. I mean, how do you reevaluate, reassess the patient just to decide if you have to wait a little bit more, or just to do the surgery only 3–6 months after the surgery? I mean, you reassess the clinical status, you just the PFT, or?
Well, our pulmonologists see the patient 3 months after and have the whole workup with 6-minute walking test, extended pulmonary function, an echocardiogram, the SPECT scan. So we have all those measurements 3 months after. And then if they have some effect, but not totally good, and there is a well-defined target area in the other lobe, then we go for surgery on the other side.
Okay. I have a lot of questions about the technical aspects. So I think that one of the more challenging decisions is just to choose which part of the lung you remove, right? During the surgery. So how do you assess these areas of the lung that you should remove? Just based on the intraoperative view, based on the previously CT scan, or how do you decide?
Actually, all the patients have a CT scan where you can measure the hyperinflation, but the CT scan is more on a lobe level. So therefore, what we have done specially is this SPECT scan. So it's nuclear medicine where you scan both for ventilation and perfusion and see if there's a marked area. Typically, I like to resect the part of the sequence 6 because, first of all, it will give a lot of benefit, and second, the upper lobe will just cover it, so it's less likely to have air leaks. But actually, we have also had patients where the CT scan shows that there is a a well-suited lobe to have resection, but then the SPECT scan shows that actually the best function is peripherally, and it is the central part of the lobe that is destroyed. So if we really went for doing surgery there, then we will, by peripheral resections, cut away the good area and leave the bad area left. There's not many publications on this SPECT scan, and we are starting to publish on that. And I know, for instance, the Zurich clinic doesn't use it. So I think it's an important add-on for the decision making. And actually, when we have the MDT conference and I see the scan with the professor of nuclear medicine, I have a map of the lung and I draw specific on that map where the resection should be. So I decide the resection areas before surgery. Then, of course, if I during surgery suddenly see a big bullet or something, I might resect that. But actually, 90% of the decision making of where to resect is done at the MDT conference, and especially with the nuclear medicine department, because they can tell me where's the function and where's the malfunction in the lung.
I asked you because I saw a video just a few days ago that from I don't remember where another group that they use ICG, interpretive ICG with an infrared camera just to identify which part of the lung is less perfused. So,
yeah, but it tells about perfusion, but it doesn't tell you so much about ventilation. So I've seen a paper about that also. So I like the idea, and it might be used in the future, but still you lack the ventilation part.
Exactly.
So we use ICG for all our segments, but we have not used it so far for lung volume reduction.
Yeah, exactly. Probably it could be another tool that we have there just for help us to decide in the practice side which part of the lung we should remove. So also, I was impressed about your recommendation that you don't use reinforced staplers, you don't use glues, and you don't use mesh. So when we watch another video from other people, usually it's a common practice, right, to use the reinforced staplers, for instance, but you don't recommend it. Why?
Well, I use glue now and then. I said like 25% I end up using the glue. The main reason for not using reinforced stapler is that when I do redo, it is seldom the stapler line. We use a tri-stapler. Well, disclosure, I am a speaker for Medtronic, but we use a tri-stapler with the different heights on the stapler, so the pressure, the force will be graduated. Second, I use the vascular stapler. It's really, really tight. But I think actually it's the most important thing is that I never do a central resection. I always do several peripheral sections. So when you have the collapsed lung, everything is fine. But when you re-expand like this, then you get the stapler line here. It's strong, but the re-expansion creates scars next to the stapler line. So therefore, the reinforced stapler, it covers the stapler line, but in my experience, it's not the stapler line that is a major problem. It is cracks next to the stapler line, or maybe a bullet, a cyst, another place that ruptures because there are more space. So I don't see any benefit of reinforced staplers. I use the Tagosil seldom. I use it now and then, but I use, I said, glue probably in 25%.
And it seems that less is more for you, because you said too that you do not use epidural catheter, and it is to me in a way contradictory, because you say no epidural, a little opioids, and epidural is aimed to reduce opioid secondary effects, and we don't want pain too. So what's the rationale for this? What do you use for pain control?
We use the same pain regimen as we use by the lobes, and actually it's been published like 2011 or 12 in European journal. So the patient begins the day before surgery with paracetamol, ibuprofen, and gabapentin. Then at the beginning of surgery, I block all the intercostal nerves with bupivacaine. At the end of surgery, the two tubes I put in the same intercostal space, and posterior to the tubes in the same intercostal space, I put in a paravertebral intercostal, whatever you will call it, catheter, put on a pump. So the patient has a continuous pump of 6 milliliters of bupivacaine in the intercostal space by intercostal nerve of the tube. And it is our experience that the main reason for pain postoperatively is actually not the incisions, it is the tubes. So we want to anesthetize the side of the tube. And we have used that for many years by our lobes now, and we use the same program. And they keep this intercostal pain catheter as long as they have the tube. The advantage is that don't morphines, it's only local, so you don't have all the side effects of the epidural, the bladder dysfunction, nausea, and other things, hypotension, and so on. And the epidural catheters has to be removed 5 days after the incision or something like that. Here, you don't have a risk of an epidural infection, so you can actually keep it quite long, the intercostal catheter.
That's a great approach. Thank you. Okay, Dr. Hansen, just let's move to talk about the indications, okay? Because this is another controversial point, because if we see the literature, probably there are some difference between the different studies that we can find. So basically, what's the ideal patient? Because, for instance, the age there is some limit in the age, because usually most of the studies just establish 75 years old. But it's not clear for us if patients older than that can be operated or not. Also, regarding the homogeneous emphysema, you just saw one of the studies analyzing this specific group. Also, with the PFT, the DLCO less than 20% or PD1 less than 20% can be operated or not. And what about that?
Well, first of all, have a look on the exclusion criteria. To me, of course, 75 years is not just a number. It has to be a sign of biological aging. So if the patient has diabetes, rheumatism, for instance, methotrexate treatment or prednisolone treatment, it will be a problem. If they had former oncological treatment, especially radiation against the chest or chemotherapy or immunotherapy, that will be an inclusion also, because the healing capacity of the tissue will be diminished. What we next really focus a lot on is the cardiological improvement. So they should have a proper pump function, not enlarged heart, and they should not have any mitral valve insufficiency or tricuspid valve insufficiency. So their pulmonary pressure should be below 40 millimeters of mercury. So that if there is, by the echocardiogram, is a slightly enlarged pulmonary pressure, then we will do a right-sided catheterization to measure precisely the pulmonary pressures. And if they end up with a pulmonary pressure more than 40 millimeters of mercury, then we will exclude them from surgery. So biological substances and cardiac problems will be an inclusion criteria. Then if they pass this and they go for evaluation for surgery, then they should still have a capacity for rehabilitation. If they're bound to a wheelchair and cannot rehabilitate, they will not benefit from surgery, and they will have a higher risk of pneumonia and other complications later on. So that is also one of the inclusion criteria, that they should have gone through a 3-month COPD rehabilitation program, and they should be able to do that program, maybe with oxygen, but they should be able to do that program, and thereby showing a certain physical capacity that they can use afterwards. They should not have too many infections. We have quite a few patients that actually are on prophylactic antibiotics. But we look at the CT scan, if they have loads of secretion, if they have severe tracheomalacia, or if they have bronchiectasis, that will be an exclusion criteria also, because they need to be pretty clean and pretty well functioning in the central bronchial tree. Else, if you have major bronchitis with infections, then you will have the air infected and they will have pneumonia and high risk afterwards.
So current smokers should be a clear contraindication, right?
Yeah, no smoking for 6 months. Actually, 2 weeks ago, we canceled a patient because when he went to the hospital a few days before surgery, he admitted that he was smoking now and then. It's also drug abuse. the second or third patient that actually died for us after surgery in the ICU, a prolonged stay in the ICU. He was he was from Spain. It's not just because of you, but he was from Spain, but lived in Denmark for a few years. He had a former history of narcotics and cocaine. And he said, well, he had not done it for many years, and he had quite damaged lungs, so we did the surgery. And then when he was in the ICU, his family came to him, and his family from Spain said, oh, he's still taking cocaine. So we are really looking closely into misuse, drugs, smoking, alcoholism, and so on. And of course, they can cheat on you now and then. There can be patients that goes under the radar, but we're really careful about that and question them really severe about that.
Okay. So just one, Dr. Hansen, just one perception, there's a personal perception, right? That this kind of procedure is, I don't know why, but it is still underused, at least here in Spain. You know, I mean, you show your result, your fantastic results. You operate almost more than 90 patients in the last in 3 years. I don't think that in Spain we have a center with this type of volume. I don't know why. Probably because of the, I mean, our reference study for this topic is the NET trial, right? That you mentioned at the beginning. So the NET trial is a little bit old, right? It was designed almost 20 years ago, and probably the results nowadays is not going to be the same. That in terms of mortality, of postoperative complications. So I think that do you think that we should update this kind of trials, because probably it could be encourage people to use this technique more and more?
We know a lot more than we did know when the NET trial was done, including what we did learn from the NET trial. But actually, if you make a survey among thoracic surgeons and pulmonologists, just arguing around what do you think of lung volume reduction, then the majority will still say, well, it's dangerous, it kills people. Because as I had the slide, they saw the title of this paper in the New England Journal 21 years ago. So there is really good evidence. What we did in Denmark as a very first step before we started it was actually we made a review in the National Danish Medical Bulletin, where one of our junior doctors made a review of the current state of lung volume reduction, the current state of emphysema treatment, written an easy, readable 3 pages report, so every doctor could easily understand it. So we have this, and then with the inclusion and exclusion criteria. So that was to educate doctors. And then together with the pulmonologists here, I've given lectures at 2 annual meetings in the Danish Society of Pulmonology. So there's a lot of education and education of our own colleagues, so they actually understand that this is beneficial.
Okay, I see. Very interesting. And my last question is about the endobronchial valves. Do you think that these are true competitions for us? There is any space for this treatment in the patients or not?
I think it should be a cooperation, and that's also why also the patients for bronchial valves are on the emphysema conference. So I see all those patients also. So, well, it can, and also sometimes you can try with the valve, and then if it doesn't function, you can do lung volume reduction surgery afterwards. We published a paper last year, Copenhagen and Zurich together, looking at lung volume reduction after valve failure, and shows that we have as good results as primary lung volume reduction. So I know some places where there's a lot of competition. I would like to see it as a cooperation.
Yeah, I fully agree. I think there is still some clinical trials ongoing about comparing these 2 techniques. Let's wait for the results. Okay. Any questions? Okay. So I think that we finished here. Thank you so much again, Dr. Hansen, for this very nice, very useful also for us lecture about this interesting topic. It was really useful for us. We learned a lot about this topic. So as I told before, hopefully in the future you can visit us here in person instead of through the screen. It's going to be really nice. So thanks again for accepting to participate with us in this educational activity.
Well, I'm happy to participate, and you have my contact information. If you have any questions or anything later on, feel free to mail me. And anyway, I hope to see you in real life at some point in your city or at a conference.
I hope. Okay. Thank you so much, Dr. Hansen. Thank you.
Thank you.
Bye bye.